Okay? So, non-GAP metabolic acidosis is often also called hyperchloremic metabolic acidosis. So the idea is the bicarb is low, but the chloride is high, so the anion gap is normal. And by far the most common causes of these are lower GI bicarbonate loss, so diarrhea or lower GI fistulas, and renal tubular acidosis. But there are a number of other causes that are worth remembering: dilutional acidosis, urinary diversions, and not really a real metabolic acidosis, but if patients have a primary respiratory alkalosis and their bicarb is lowered to compensate for it, there's no change in the anion gap. So if you just look at the serum values, they look like they have a non-GAP metabolic acidosis. So just something not to be fooled by. Okay, so this is an attempt to explain why non-GAP acidosis occurs. And let's give an example. A patient has diarrhea. So for the purposes of simplification, let's assume diarrhea is just the generation of sodium and bicarbonate-rich fluids. So that would lower your sodium. Sorry, the arrows didn't show up here. But this would lower your sodium and bicarbonate simultaneously. And so your anion gap shouldn't change, right? If the number on the left goes down by 2 and this number on the right goes down by 2, the anion gap should be unchanged, which is another way of saying that when you're having diarrhea, you're not adding any other unmeasured anions into the mix, okay? Now, as you have diarrhea, you might replete the patient with sodium chloride, which would raise your sodium. Oops. Raise your sodium and your chloride, or your kidneys might attempt to retain sodium and chloride to maintain your volume. So the cation, sodium would go up, and the chloride would go up the same amount. Again, anion gap should remain unchanged. So all of these are basically saying that if you don't add any exogenous anions, your anion gap should remain unchanged. Similar things apply in proximal RTA, that the proximal tubule will be wasting sodium and bicarb. Distal tubule might attempt to compensate by retaining the sodium with chloride, but regardless of how we juggle these three ions, they would remain in the same proportion, and there'd be no change in the anion gap. In a distal RTA, the problem is the retention of hydrochloric acid that's not being excreted, and that would raise your chloride but lower your bicarb by the amount that you're retaining hydrogen ions. Again, no change in your gap. Okay, so when you have a patient of non-GAP acidosis, usually we're trying to figure out, do they have diarrhea or do they have an RTA? Or if they already have diarrhea, is this all from the diarrhea or do they have a superimposed RTA? And by far the most useful test that you can do is to determine the urine anion gap, and I'll explain why. So what's the urine anion gap? It's the urine sodium plus potassium added together minus the urine chloride. So notice that this is a little different from the serum anion gap. We include the potassium because there's a lot of potassium potentially in urine, much more than in serum. And in our version of it, which is the conventional version, we don't include bicarbonate, because most urines don't have much bicarbonate, and it's very hard to measure by a lab. What's the normal range? It depends. There's no real normal range, and it really depends largely on one's diet. And how does this work? So just like any anion gap, it's dependent on electroneutrality. The total number of negatively charged ions and positively charged ions in any fluid has to be equal, all right? So the total anions includes those that are measured and those that are unmeasured. Same for the measured cations and unmeasured cations. And if you bring the measured over to the left, the measured cations, that's sodium and potassium, minus the measured anions, chloride, must equal the unmeasured anions minus the unmeasured cations. So this is the excess of unmeasured anions over unmeasured cations in the urine. So what are those unmeasured ions? So the unmeasured anions are things like sulfate, phosphate, bicarbonate if it's in the urine, and organic anions, and unmeasured cations are things like calcium, magnesium, and ammonium. And the important thing here is that the only ones of these that really change to any significant extent are bicarbonate, which is usually not present in urine under normal physiologic conditions, and ammonium, which varies in order to try and excrete acid depending on diet or acid load. So how's this helpful in acidosis? Well, in the setting of acidemia, the kidney is trying to get rid of acid and retain bicarb. So urine bicarbonate should be essentially 0, and urine ammonium, positively charged ion, should be very high. The kidney revs up ammonium's excretion to try and get rid of acid. And so the urine anion gap, which is the unmeasured anions minus the unmeasured cations, should be low, right? So the higher this ammonium is, the lower your urine anion gap is. How low is shown here. So here's this classic paper from Daniel Battier in the New England Journal from 1988, showing that if you have diarrhea, as you get progressively more acidotic, you excrete more and more ammonium. That's shown on the y-axis here. And the more ammonium you excrete, the more low your urine anion gap is. In fact, it's negative. So that's reflecting high ammonium in the urine. Conversely, patients in this case who had distal renal tubular acidosis, so they had the same degree of acidosis, but their ammonium did not increase. So that's the defect in distal RTA, and so they have a higher urine anion gap. Okay? And the cutoff is about an ammonium excretion of about 25. Greater than 25 is an appropriate response to acidosis. Less is not. And it turns out that just by coincidence, sheer coincidence, this corresponds to an anion gap of 0. And so what we can say is that if the urine anion gap is less than 0, in other words, if it's negative, that's appropriate ammonium excretion, as you would expect in diarrhea. Greater than 0, positive urine anion gap suggests that there's a renal defect in acid excretion. Okay? So here's a little bit of small print for those of you who are curious as to why we don't just jump to the urine pH. Seems the urine pH would tell you whether it's an acidic urine or alkaline urine. And this is not something that you need to memorize, but is useful to know. So in Daniel Battier's paper, he showed that there were some patients with diarrhea who were profoundly volume depleted. And one of the signs of volume depletion is your urine sodium gets very low. So when your urine sodium gets very low, your urine pH gets very high. Why is this? Because these patients aren't delivering enough sodium to their collecting duct for that sodium to be reabsorbed in exchange for hydrogen ion secretion. So they have, if you will, an acquired impairment in acid secretion that's simply because they're very dry. So the urine pH can't distinguish whether it's an RTA. So if you see this high urine pH, you might say, the urine pH is 6.5, this patient must have an RTA. But it's not. It's just a diarrhea patient who's very, very, very dry. So I suggest you start by looking at the urine anion gap. Okay, so here's the simplistic way of using it. Negative urine anion gap in the setting of a non-gap acidosis, diarrhea, positive or renal tubular acidosis. Okay, I think I'm going to skip this and just go straight on to the renal tubular acidoses. So this is a topic of huge confusion to many, many people, and it really needn't be. Renal tubular acidosis is incredibly simple, and so I'm going to try and give you the simplified version of it. So certainly for the purposes of the boards, and I think actually for the purposes of most clinical management, you just need to recognize 3 types. Proximal, which we also call type 2, classic distal, which is type 1, which is hypokalemic, and hyperkalemic distal, which is type 4. Okay, so type 1, type 2, and type 4. And to really understand how these work, you just need a very simplistic concept of how acid excretion occurs in the renal tubule. So this is not what you learned in renal physiology. This is the dumbed-down version. But essentially, what happens is that before you can excrete any acid at all, when your blood is filtered to generate glomerular filtrate, it has a huge amount of bicarbonate that's filtered that you don't want lost. So you first have to reabsorb all of that bicarb, and most of it's being reabsorbed in the proximal tubule. Once you've reabsorbed all the bicarbonate, move on to the collecting duct, now you can start to secrete net acid. So the proton pump, the collecting duct, is secreting acid, but if you just secreted hydrogen ions, you couldn't really get rid of a lot of acid. So you need a buffer, which basically is something that carries the acid out into urine without making the urine extremely acidic. And so that's what ammonia does. Ammonia basically mops up the acid to make ammonium, which you excrete into the urine. So in a proximal RTA, the problem is simply that they can't reabsorb bicarbonate. So they waste bicarbonate. In a classic distal RTA, the problem is that they can't secrete hydrogen ions into the urine. So they don't generate ammonium and they don't lower the urine pH. In a type 4 RTA, the major problem is the inability to generate enough ammonia to mop up the hydrogen ions. So they can still secrete hydrogen ions and they can lower the urine pH, but the amount of acid that's actually gotten rid of from the body is insufficient because there isn't really much ammonium being excreted. So in all of these cases, there's decreased ammonium excretion, and that's why the urine anion gap works in all of them. And this is just a small print that there's some cases which sort of look like type 1 and type 4. So again, here's a perhaps overly simplified version of how you diagnose RTAs. And this is about all you know to figure out what each patient has. So first you look at the serum K. So it's going to be low in a proximal RTA, a type 1 or classic distal, as it is in diarrhea, whereas a type 4 is by definition a hyperkalemic RTA. Urine anion gap, as we said, negative in diarrhea and positive in the distal RTAs. In proximal RTA, it's variable, and we'll come to why. Urine pH, the most useful point of the urine pH is to distinguish between type 1 and type 4. So type 1, as we recall, there's a specific defect in acid secretion into the lumen of the collecting duct. So they can't lower their urine pH. In type 4, they can lower their urine pH just fine. They just don't get rid of enough ammonium to get rid of their daily acid load. And then some other clues that are helpful to distinguish between them. So in a proximal RTA, most adult proximal RTAs are associated with Fanconi syndrome. So this is a very useful clue. And the distal RTA, type 1 RTAs often have nephrocalcinosis. So this is not something you need to memorize, but this is often a cause of confusion. How do we make the diagnosis of a proximal RTA? So the issue here is that in untreated proximal RTA, your bicarb is very low. If you treat patients with bicarbonate and raise the serum bicarbonate, they look completely different. Okay? So under this circumstance, the filtered load of bicarbonate is very low, and so if your bicarbonate drops enough, the filtered load drops enough that there's enough reabsorption of proximal tubule to completely reabsorb it, and so then you don't have any urine bicarbonate, and your urine pH can be appropriately acidic, and your urine anion gap negative. As you give bicarbonate and attempt to raise the serum bicarb, which is extremely difficult to do in a proximal RTA, you actually spill more and more bicarbonate into the urine, and so the urine becomes alkaline and the urine anion gap is positive. So depending on where you are on this spectrum, you might get different urine pHs and urine anion gaps. So diagnosing a proximal RTA is actually quite hard if you want to do that definitively. You often have to test them before and after you give bicarbonate, or conversely, give them ammonium chloride and send them back the other way. The reality is, for all practical purposes, it's not really that necessary. And more importantly, most adult forms of proximal RTA are going to be associated with Fanconi syndrome. And certainly if you get a case in the boards, they're not going to just show you an RTA and have you try and figure out whether it's proximal or not. That would be too complicated for the boards. They will give you a patient that has Fanconi's and expect you to recognize the features, which in addition to hypokalemic non-GAP acidosis are glycosuria despite normal glycemia, generalized aminoaciduria, and hypophosphatemia with urinary phosphate wasting. And if you ever need to figure out urinary phosphate wasting, probably not something they'll give you on the boards. You can just calculate the fractional excretion of phosphate, and if it's greater than 5%, usually it's often very much higher, that would suggest renal phosphate wasting. And the other feature of Fanconi's, hypouricemia. So some of the causes of renal tubular acidosis are shown here. In the textbooks, you see a lot of the inherited causes that are in children. In adult nephrology, we don't tend to see those. Proximal RTAs in our hands are usually either caused by plasma cell dyscrasia or a drug like ifosfamide or some of the antiretroviral drugs. Type 1 RTA is usually either due to an autoimmune disorder like Sjogren's or lupus, or occurs in patients with chronic liver disease, but it can be mimicked by amphotericin treatment, and occasionally you'll see patients with medullary sponge kidney, which is a congenital but not an inherited disorder. And type 4 RTA is usually either due to, I didn't put this here, but adrenal insufficiency technically causes type 4 RTA. Hyporeninemic hypoaldosteronism that you heard about earlier is the most common cause that we see, or drugs that inhibit the renin-angiotensin-aldosterone axis, like ACE inhibitors, ARBs, renin inhibitors, and so on. But you should be aware that some of these renal disorders that predominantly affect the tubular interstitium, like sickle, lupus, obstruction, HIV, can also cause type 4 RTA. This is just to remind you that Fanconi syndrome is extremely common with a class of nucleoside reverse transcriptase inhibitors that are called acyclic nucleoside phosphonates. So that includes adefovir, cidofovir, and tenofovir. Tenofovir is still commonly used in HIV. Some of these are used for different viruses, BK virus, sometimes used for Hep B, and so on. And they share the common characteristic of being transported in the proximal tubule by OAT1, the organic anion transporter. And like all retroviral reverse transcriptase inhibitors, it's toxic to the mitochondria. And since the mitochondria and the proximal tubule is the engine that generates energy for sodium-dependent reabsorption of solutes, when that's inhibited, you can have Fanconi syndrome. These drugs are also nephrotoxic and cause actual acute kidney injury due to ATN. And ritonavir, we think, inhibits the exit of these drugs from the proximal tubule. So a combination of tenofovir and ritonavir seems to be particularly toxic. Plus, these are all renally excreted, so renal insufficiency can increase toxicity. Okay, in terms of treatment for renal tubular acidosis, I'll start with type 4. So in patients with type 4 RTA, they usually do not have a very severe acidosis. Their major problem is actually hyperkalemia. And so the treatment of type 4 is to treat the hyperkalemia. For these other two, you want to correct the acidosis with alkali. And so that's either bicarbonate or citrate, either in the form of sodium or potassium salt if you want to correct their potassium as well. The major distinction between them is in type 1 RTA, the reason those patients get acidotic is because they have a defect in renal excretion of acid, so they can't excrete their daily acid load. So that's the acid that's generated primarily from dietary ingestion of meat. And so that's generally about 1 to 3 milliequivalents per kilo per day. So these patients generally need something like 30 milliequivalents of sodium citrate twice a day or 3 times a day. That's sort of a typical dose. Proximal RTA is different. These are patients who are wasting bicarbonate into the urine. And as I mentioned before, the more bicarbonate you give in an attempt to raise their serum bicarbonate, the more gets lost in the urine. So they often need very, very high doses of bicarbonate in order to correct their serum bicarbonate reasonably close to normal. Okay, urinary diversions. So these are things, nowadays the main type of conduit that's used is an ileoconduit or continent diversions. And 20% of ileoconduits and 13% of continent diversions have a metabolic acidosis. The reason is that the urine that's coming out goes into this intestinal loop, which, unlike the bladder, which is essentially impermeable to most electrolytes, the intestinal loops are permeable to electrolytes, and particularly to the reabsorption of ammonium and chloride. So these patients don't excrete enough ammonium chloride, so they look exactly like a distal RTA. They have a normal anion gap acidosis, a positive urine anion gap. Also, the longer the urine is in contact with the intestinal wall, the more severe this reabsorption is. So oftentimes they'll have a chronic, reasonably well compensated acidosis, but they come into hospital with an exacerbation of the acidosis because of obstruction of the outlet for the diversion. So the urine's sitting in the intestinal loop longer than it should. Dilutional acidosis, so this frequently happens when patients get resuscitated with large volumes of isotonic sodium chloride, burns patients, and so on. And essentially what you're doing is adding sodium chloride and water to the serum, but diluting down the serum bicarbonate. So that leads to a non-gap acidosis. The solution is to give bicarbonate with the sodium chloride or give a balanced salt solution like lactated ringers. A brief mention of bicarbonate treatment for metabolic acidosis. There is, as you know, a significant controversy over whether you should use bicarbonate at all to treat some of the anion gap acidoses like lactic acidosis and diabetic ketoacidosis. And the reason is the organic anions, if you treat them properly, will actually get metabolized back to bicarbonate. So in theory, it should be self-limiting. Conversely, if you give bicarbonate, it combines with the acid to form CO2 that actually is permeable to and enters cells and causes intracellular acidosis. And it's thought that that might actually be detrimental in certain tissues like the heart. So in general, we try and avoid treating the acidosis until they're profoundly acidemic. My threshold is somewhere between 7 and 7.2. Some critical care intensivists let the pH go down to 6.9 before they do anything. Also, because of our particular patient population, I'd recommend that you have a much lower threshold for treating patients who have renal insufficiency, because obviously they have less ability to excrete the acid. In general, for the purpose of the boards and actually for most clinical applications, you don't really need to calculate the bicarbonate deficit in order to correct it. It's often done empirically. If you want to do that, the formula is here. Probably the most important thing to understand is that the apparent volume of distribution of bicarbonate increases as the acidosis gets worse. What I mean by that is when the bicarb gets down to very low levels like 4 or 5, it doesn't come down much further even as the more acid enters the blood. Instead, as I mentioned, that acid gets buffered elsewhere, for example, intracellularly. So a patient with a bicarb of 5 may have much more acid load than you would anticipate. And when you start giving them bicarb, you need to give them a lot of bicarb to get them up that first step from 5 to 8 to 10. And then as the bicarb comes up, the amount of bicarb needed gets less and less. There are a number of ways of giving bicarb, but generally giving it isotonically if you can, so 150 milliequivalents of bicarb per liter of water is probably the best if you can. Okay, so moving on, the last 15 minutes or so, we'll breeze through metabolic alkalosis. There are a number of overlaps here with some of the discussion about hypokalemia, as you'll see. So when you have a patient that has metabolic alkalosis, the first question is, what caused it? What's induced the metabolic alkalosis? And rationally, it's got to be either they've ingested alkali, or they've lost acid from the body, which is either from the GI tract or the kidney, or there's shift from the cells. Okay? So what causes ingestion of alkali? Obviously, antacids are all alkali. Citrated blood products, also patients that get massive transfusions of stored blood, which have citrate, can become alkalotic from the citrate itself. But bear in mind that the kidney has a remarkable ability to excrete alkali. So it's very unusual to get alkalosis from these alone. An exception to that rule is milk alkali syndrome, which is now being renamed as calcium alkali syndrome because it's often not caused in the current era by milk, but actually by ingestion of calcium carbonate. So in the era when lots of patients are getting recommended calcium carbonate to treat or to prevent osteoporosis, this is becoming increasingly common and is said to account for about 10% of patients in hospital with hypercalcemia now. And essentially what this is a combination of metabolic alkalosis with hypercalcemia and acute kidney injury. And these three tend to be synergistic with each other. So if a patient is ingesting calcium carbonate, the carbonate is an alkali, so that alkali load theoretically can cause an alkalosis. The calcium could theoretically raise your serum calcium a little bit. Now, sorry, the arrows here haven't shown up, but as you become alkalotic, this tends to stimulate your calcium entry channel in the distal convoluted tubule, TRPV5, and increase calcium reabsorption and decrease excretion. So the alkalosis actually exacerbates calcium overload. Conversely, hypercalcemia itself causes a natriuresis because it actually stimulates the calcium sensing receptor in the thick limb and inhibits the NAK2Cl cotransporter. So if you will, calcium itself acts like a loop diuretic, and as it causes natriuresis, the increased sodium delivery to the collecting duct increases acid secretion, and so that worsens the alkalosis. So it's a bidirectional process. And then on top of this, the hypercalcemia causes both a pre-renal picture, so calcium is vasoconstrictive, or actual renal failure from ischemic ATN. And acute kidney injury, of course, decreases the excretion of everything, including alkali and calcium. So these three processes together form, if you will, a perfect storm and feed into each other to drive calcium and pH higher and higher. So important to recognize. Okay, so next is GI loss. So obviously gastric secretions are very rich in acid, so vomiting or nasogastric suction commonly cause metabolic alkalosis. GI loss of chloride itself can also cause a metabolic alkalosis. I put this in small print, not something that will come up in the boards, I'm pretty sure. And then on this side, we have renal loss of acid. So acid is secreted in the collecting duct in response to sodium reabsorption through ENaC. So if you deliver more sodium to the collecting duct, it'll be reabsorbed in exchange for hydrogen ion secretion. So all of the diuretics, Barters and Gittlemans do that. That sodium reabsorption and the hydrogen ion secretion is stimulated by aldo, so all the hyperaldo states are associated with metabolic alkalosis. And then there's this funny disorder of post-hypercapnic alkalosis, which is essentially a renal compensation for respiratory acidosis gone awry. And then finally, cellular shift. Well, let me just show this first. So here's a collecting duct in which sodium is being reabsorbed from the tubule side and pumped out basolaterally. And this generates a negative potential that can drive either K secretion or hydrogen ion secretion. And this is all stimulated by aldosterone, which is in turn stimulated by the renin-angiotensin axis. So if you have increased sodium delivery to the collecting duct, so it's inhibited earlier in the tubule, Barters, Gittlemans, lupothiazide diuretics, you'll get more sodium reabsorption and K and hydrogen ion secretion. So that causes a hypokalemic metabolic alkalosis, but the blood pressure is normal or low. Conversely, if you have anything that increases aldosterone or aldosterone effect over on this side, it would cause increased sodium reabsorption and K and hydrogen ion secretion. So you'd get hypertension and a hypokalemic metabolic alkalosis. So that includes primary hyperaldo, renal artery stenosis, Cushing's, as we mentioned earlier, and Liddle's, where the sodium channel itself is overactive. So you saw this picture already in associated with hypokalemia. So hypokalemic metabolic alkalosis with hypertension is hyperaldosteronism until proven otherwise. And here's the differential diagnosis. And here again is the workup that you would expect to do depending on which arm of this you think is suspicious. Okay, a little frozen here. It's frozen, David. Oh, here we go. Okay, so just a brief mention of post-hypercapnic alkalosis, which you may encounter. So these are patients with chronic CO2 retention, like COPD patients, who normally have compensatory increase in their bicarbonate, so it's retained by the kidney in order to try and partially correct the pH. And they're doing fine until they come to hospital and get mechanical ventilation, and the goal of mechanical ventilation is to try and get the PCO2 down, right? But if you bring down the PCO2, but the serum bicarbonate remains high, then these patients will have an alkalosis and a high serum pH, okay? Over the course of time, that corrects, but it takes time. It only occurs if you have adequate kidney function and if you're well hydrated. If you're dehydrated, the kidney is unable to excrete alkali rapidly. So these patients often appear to be alkalemic and alkalotic, but if you just hydrate them and give them a little time and they have normal renal function, it corrects by itself. Okay, and finally, cellular shift, just to remind me that hypokalemia itself also exacerbates metabolic alkalosis, and one reason is because it exchanges with hydrogen ions within the cell, so it shifts hydrogen ions from the blood into the cell, and it also increases the HK ATPase in the medullary collecting duct, so it actually causes secretion of hydrogen ions in exchange for K retention. Okay. And then one thing that doesn't end up on this list, but also can cause metabolic alkalosis, is contraction of the extracellular fluid volume. So if you want to think of it simplistically, this is essentially the opposite of a dilutional acidosis. But here you're losing sodium chloride in excess of water. So if you imagine if you lose chloride and water, your concentration of bicarbonate will increase. But more importantly, as you become volume contracted, the kidney loses its ability to get rid of alkali. And the reason is when you become volume contracted, the kidney tries to retain salt and chloride. So what it does in the proximal tubule is to increase sodium reabsorption, and that sodium reabsorption is largely with bicarbonate. So it's retaining sodium to try and preserve extracellular fluid volume at the expense of making the alkalosis worse. And then as there's less chloride or no chloride being delivered to the collecting duct, where chloride is normally reabsorbed in exchange for bicarbonate secretion in beta-inticulated cells by a transporter called pendrin, you can't get rid of bicarbonate by this route, and so again you retain bicarbonate. So volume contraction tends to impair the ability of the kidney to excrete bicarb. Okay, frozen again. Okay, here we go. So those are the things that cause alkalosis, but regardless of the cause, alkalosis can only be maintained if there is some components of impaired renal excretion. Okay? Otherwise, all that excess bicarbonate would be excreted by the kidney. So patients have to be volume contracted, or have hyperaldosteronism, or hypokalemia, or just have frank renal insufficiency in order to have persistent alkalosis. So if you take someone with normal renal function and give them a bunch of antacids, very unusual to get any alkalosis whatsoever. Take a patient with CKD stage 4, give them some antacids, they rapidly become alkalotic. Okay, this is not for you to memorize, that's why it's on the yellow slide, but something that I think is helpful to understand, which is the time-dependent change in urine lytes with vomiting. So it's an example of what happens to your urine lytes when you become alkalotic, and vomiting is one of the pure forms of alkalosis. And what happens early on is that your urine sodium and bicarbonate go up. So this is, the kidney is trying to get rid of sodium bicarbonate, so your urine's very alkaline, and try and correct the alkalosis. Okay, that's early on. However, later on in vomiting, patients become more and more volume depleted, and the urgency for preserving extracellular fluid volume and sodium-containing fluids supersedes that of correcting the acid-base disturbance. So later on, this urine sodium falls, like you might see in someone who's volume depleted. They're trying to reabsorb sodium, as I mentioned, the proximal tubule that's reabsorbed with bicarb. So the urine bicarb actually falls, and their urine pH becomes acidic, which is a phenomenon that's often called paradoxical aciduria. So even though the patient is alkalotic, they're making an acidic urine. Okay? Now, the reason that I show this is for one important reason. So that you see that the sodium in the urine varies enormously, as does the bicarbonate pH. But there's one thing that's constant here, which is that the urine chloride is always low. So when you want to know whether someone's volume depleted and they have a metabolic alkalosis, this is the one condition in which you don't use the urine sodium, you use the urine chloride instead. So how that becomes useful is here. So here are the 4 major causes of hypokalemic metabolic alkalosis that you're likely to have to figure out and distinguish between when there isn't an obvious cause that's recognized. So undiagnosed hyperaldosteronism of some form, surreptitious vomiting, surreptitious diuretic abuse, or a patient with undiagnosed Bartels or Gittelmans. So hyperaldosteronism is easy. Those patients are usually hypertensive. All of these other cases, the patients are either normotensive or hypotensive, and sometimes volume depleted. So here the urine chloride is helpful because it's low in surreptitious vomiting. Urine sodium might be low, but it's not very reliable. Whereas in diuretic abuse and Bartels and Gittelmans, these are conditions of renal sodium chloride wasting. So the urine chloride, by definition, is always high in these disorders. Okay? Now, how do you distinguish between diuretic abuse and Bartels or Gittelmans? The answer is it's very hard. It's not always that easy. But generally, you want to assay the urine for diuretics and try and catch the patient when they're taking the diuretic. Okay, treatment of metabolic alkalosis. Obviously, you want to treat the underlying cause. You can't correct metabolic alkalosis by your own kidneys unless you're volume replete. So we always correct the extracellular volume, and you want to correct them with chloride, because chloride depletion seems to play an important role, and you want to correct the K because hypokalemia impairs the ability to excrete alkali. So K and chloride-containing fluids help tremendously. If you have a patient who's not volume depleted but actually edematous, so a good example is patients with heart failure who are being diuresed and develop alkalosis, you can try a drug that will alkalize the blood but get rid of salt, and that's what acetazolamide does. And ultimately, in some patients who are very severely alkalotic, you have no choice but to dialyze them. And here's some suggested additional reading for you. Thank you very much.